Thank you for including me in Class 2020. My name is Deborah Jacobs, and I'll be speaking on the use of contact lenses in ocular surface disease. I'm faculty at the Cornea Service at Massachusetts Eye and Ear Infirmary, Harvard Medical School in Boston, Massachusetts, United States of America. First, some historical perspective on therapeutic soft contact lenses. The concept of a bandage or therapeutic as opposed to a cosmetic contact lens was introduced in the 1970s. The prototype was the Bausch & Lomb Plano T. I like to joke that the T stands for thick. It was a hydrophilic hydrogel with low water content and low oxygen permeability. The DK was 9.2. This lens reduced pain, promoted epithelialization, and sealed leaks. It induced edema, which is sometimes good, for example, when there's a laceration or perforation or wound leak, and it's sometimes bad, as when you're using it to help heal an epitheliopathy such as bullous keratopathy from endothelial dysfunction. The historical perspective on scleral lenses for ocular surface disease emerges in the 1980s, when from around the world, different investigators considered the use of scleral lenses made of gas-permeable plastic instead of standard PMMA for patients with distorted corneas and ocular surface disease. In 1990, Shine, Rosenthal, and Ducharme reported on a series of 15 patients that had visual rehabilitation with scleral lenses. Only 2 of the 15 had ocular surface disease. 2 decades later, the same group reported their experience with the therapeutic use of scleral lenses. And in that series from 2010, in which I was one of the authors, nearly half of the 80 patients seen over a 6-month period in 2006 had primary indication of ocular surface disease, indicating the growing appreciation of these lenses, not only for ectasia and astigmatism, but also for ocular surface disease. Since this talk is intended to be clinical, I thought I would then present some clinical pearls, and first I'll discuss clinical pearls related to therapeutic soft lenses. My suggestion is you get to know one's lens well, and below are listed a few of the options that are FDA approved in the United States. They're all silicone hydrogel, which is good for therapeutic use because it's got high DK oxygen, and also a rigid modulus, which allows for the formation of a tear lens under the lens. My recommendation is that you avoid daily disposables. These are generally of low DK, and they're not manufactured or marketed for extended wear, which is how most therapeutic soft lenses are used. You should place a lens on the eye and confirm good centration and movement. If these aren't satisfactory, you'll have to play with the base curve, which might require switching brands, as each brand typically comes in only 1 or 2 base curves. I then recommend that you leave the lens on the patient's eye for an office trial of 30 minutes. They should report an ah effect, that is, relief of symptoms. If they're not made much more comfortable by the lens, then they will be squeezing and it won't be there after a few hours. You should look for tolerance and retention. And now, some more clinical pearls. Daily wear can be an option to consider because it's certainly safer as far as infection. The problem is that for therapeutic use, it's very difficult for a novice patient to learn to insert and remove, and the process of doing so, even with an experienced patient, may be a challenge for fragile epithelium. It is the safest soft lens option, but for bullous keratopathy and other problems like recurrent erosion where the surface is prone to breakdown, extended wear the benefits may outweigh the risks. Extended wear is defined as under closed lids. Certainly there is high patient acceptance. Typically, these patients are brought in weekly, bi-weekly, or monthly to the office to have their current lens swapped for a brand new one. Some patients who are experienced lens wearers may be able to do this themselves. Certainly, with this mode of wear, there is higher risk of microbial keratitis. And now, even more clinical pearls for the therapeutic use of soft lenses as a bandage lens. Certainly, if the patient has no prior lens wear experience, I recommend bringing them back for a one-day check to make sure that the lens is accomplishing its goals of good comfort and good retention without any sign of tight lens syndrome. I'd then bring them for a 1-week check, and depending on deposits, the type of lens used, how the lens looks, consider going a second week or swapping for a fresh lens then. If retention is a problem, consider moving to a contour or other large diameter lens. These lenses typically are made of hydrogel and not Sci-Hi, and so you may sacrifice increased oxygen transmission for improved retention, but it's a choice that may have to be undertaken. The issue of antibiotic prophylaxis is controversial. Typically, I prophylax with a soft lens only if there's a geographic epithelial defect. Some clinicians prophylax all patients who are going to be wearing a lens overnight or a soft lens over any sort of epitheliopathy. And others prophylax only high-risk patients, such as those with underlying disease or on topical steroid. As far as rigid gas permeable scleral lenses for ocular surface disease, there are many commercially available rigid gas permeable lenses made of high decay materials, and below are listed a few of the brands. In many of these lenses, the profile is based on the superposition of spheres of increasingly flat base curve as you go out more peripherally. The vault of the optic of these lenses is directly related to the base curve of the optic portion. Some of these lenses offer new tangential profiles, toric designs, and options for channels and microvaults. Typically, fitting these lenses requires an experienced and motivated contact lens specialist. Ideally, the contact lens specialist and a cornea specialist must work together to decide what risks are worth undertaking in these eyes with underlying disease. It's worth noting, in the first reports that emerged from the U.S. on the use of gas-permeable scleral lenses in ocular surface disease in 2007 and 2008, in each report, the patients came from centers where optometrists and ophthalmologists were working together in the care of patients. And now, some clinical pearls on rigid gas permeable scleral lenses. Typically, mini sclerals and corneal sclerals may be pitched as scleral lenses. My concern with these is section. It may be difficult to achieve minimal motion but no suction, and it may be difficult to achieve no air intrusion but no suction. Suction is a challenge for compromised epithelial tight junctions, and it may lead to epithelial edema, which causes symptoms of haze, halos, and fogging. It may lead to bullae, and ultimately to surface breakdown. In order to avoid suction, tear ventilation, that is, tear exchange under the lens, is required. It is tear ventilation that allows not only for oxygenation, but the avoidance of mechanical challenge to compromised epithelial tight junctions. So, a mini scleral or corneal scleral that fits, that is comfortable on the eye without excessive vault and with good vision, may not actually be physiologic if suction develops over time. A lens such as this may not be appropriate for ocular surface disease. PROSE treatment, which takes advantage of customized scleral lens prosthetic devices typically involves a lens that is fluid ventilated. When the PROSE device is placed on an eye, such as the one shown at the bottom with filamentary keratitis in the setting of ocular graft versus host disease, the features of the device allow for improvement of the mucin epithelial interface such that the filaments improve and the staining resolves over just a few hours. This improvement is related to good oxygenation and fluid ventilation with little mechanical insult. This report is a gold standard that other series should aspire to in assessing the response to the use of gas-permeable scleral lenses, both in ectasia and in ocular surface disease. And these series published by authors from Boston Foundation for Sight in collaboration with authors at Brandeis University. They reported on every patient seen in consultation for scleral lens from January to June 2006. I was one of the co-authors. In this report, the mean change in visual acuity was 4 lines, greater in ectasia astigmatism, less in ocular surface disease. The change in visual function was over 20 points on the NEI-VFQ, and this was the same for both patients with ectasia astigmatism and for ocular surface disease. Very few studies on rigid gas-permeable scleral lens equal the number of patients and the rigor of outcomes in that previous study. There are no studies that directly compare bandaged soft lenses, rigid gas-permeable scleral lenses, or PROSE treatment. In most reports on scleral lenses, ocular surface disease patients are a small minority. As far as the use of therapeutic contact lenses in general, I like to say that ocular chronic graft versus host disease is the poster child for therapeutic contact lens. That's because there is good data and publications for several modalities: soft lenses, scleral lenses, and PROSE treatment. And in these reports, there is an excellent response that is measured by many metrics, including ones that are patient-reported, such as the NEI-VFQ-25 and the OSDI, and ones that are objectively measured, such as best corrected visual acuity, staining, and resolution of filaments and persistent epithelial defects. The levels of improvement in both patient-reported symptoms and signs are not equaled by any thus far reported medical interventions for ocular chronic graft versus host disease. I was a co-author on a study from Boston Sight published in 2007 reporting on 33 patients with chronic graft versus host disease. This was every GVHD patient treated at Boston Sight over 3 years. And when the data was collected and reported in 2006, not one was lost to follow-up and not one had died. We used a non-validated instrument, but with that found that 50% had the highest level of improvement in pain and photophobia, and 90% had improvement in reading and driving. In the same year, investigators at the Fred Hutchinson Cancer Center reported on the impact of PROSE treatment as measured with the OSDI, which improved from a mean of 81 of 100 points to 21 within 2 weeks, and improved further down to 12, which is considered the limit of normal in patients with CGVHD. In that same year, Investigators from Loyola in Chicago reported on their experience with therapeutic soft lens for chronic ocular surface disease and GVHD. 7 patients were fitted bilaterally with the Air Optics night and day to be worn on an extended wear basis with replacement at 7 days, and this pattern of wear continued for 1 month. The OSDI improved among these patients from 76.8 to 31.2. Best corrected acuity improved 2 lines. There was no change in Schirmer's, in staining, or in tear breakup, and importantly, there was no adverse events or complications in what are perceived to be high-risk population. The following year, investigators at Mayo Clinic reported their experience with the Jupiter lens and ocular CGVHD. In this case, the lens was a full scleral lens of 18.2 millimeters diameter. They reported in 5 patients there was a subjective improvement in comfort with improvement in vision in 7 of 10 eyes. The Boston site experience was confirmed independently at a network site that used PROSE treatment, and among 40 patients with CGVHD seen over a period from 2009 to 2013 that received PROSE treatment, 90% had improvement in best corrected visual acuity. 8 had died, 3 stopped wearing devices. Of the 29 remaining, the OSDI improved to similar levels as in the other studies, from 72.6 down to 21.1, and there was resolution of persistent epidefects and filaments. A confirmatory study of the experience with therapeutic soft lenses emerged that same year as well. This was from the Fred Hutchinson Cancer Center. 20 patients with CGVHD wore therapeutic soft lenses for 3 months. This was of the 40 that enrolled. There were a variety of lenses used, listed below. The choice depended on comfort and retention, as well as intention to use the one with highest DK, at least initially. All these patients received antibiotic prophylaxis in the form of ofloxacin or moxifloxacin 4 times daily. There are other topical medications, including steroids, cyclosporin A, serum tears, and so on, were continued, and these patients were assessed at 2 and 4 weeks and then 3 months. Punctate erosions improved in OSDI, the least subscales, and eye symptom scales improved. There were no infections or complications among the 20 who wore these lenses in over 3 months. The investigators concluded that this widely available option was safe and effective in 50% of patients. This is important for patients who don't have access to specialty lens fitters or PROSE treatment. In summary, extended wear soft contact lenses, scleral lenses, and PROSE treatment can all be effective for the ocular surface disease that occurs in chronic graft versus host disease. There were no complications related to the soft lens, PROSE, or scleral lens wear. However, some patients dropped out, in part related to underlying disease or inadequate effect. These patients did well, despite being sick and immunocompromised. Prophylactic antibiotic was not part of the regimen except for the extended wear soft lenses, and sometimes topical steroids remained as part of the regimen. Besides the substantial literature on the use of therapeutic lenses in chronic graft versus host disease, there are reports of therapeutic lens use in recurrent erosion syndrome, mostly extended wear soft contact lenses, also bullous keratopathy, but this indication has gradually disappeared due to improvement in cataract surgery techniques. Scleral lenses and PROSE treatment are described for exposure keratitis, and for Stevens-Johnson syndrome, scleral lens, PROSE treatment, and tear-exchanging limbal lenses are described. Interestingly, there is generally not good success with Sjögren syndrome, that is, dry eye syndrome related to underlying autoimmune disease that's serologically proven. My clinical experience is that we had less than 25% success rate with PROSE. This is because many of these patients were intolerant due to underlying neuropathy, that is, corneal neuralgia with secondary hyperalgesia. My experience is that these patients may do better for their ocular surface disease with high DK, high modulus, daily disposable, soft contact lenses.
Hello, everybody. My name is Jason Nichols, and I'm the program chair for the Global Specialty Lens Symposium and our new meeting, the Global Myopia Symposium. We look forward to bringing you cutting-edge information each year, and again, we look forward to hosting you in 2021. Thanks, everybody.
For the remainder of this session, I thought I'd review some clinical case experience. This is a 34-year-old with lupus who developed Stevens-Johnson syndrome. She was referred for PROSE treatment when she had persistent defects 4 months after discharge from the hospital from acute Stevens-Johnson syndrome that failed to respond to the usual topical regimens. Boxes A and D show her appearance at presentation with a persistent epidefect and underlying edema and haze. Continuous wear of the PROSE device was undertaken as reported in the AJO paper from 2013. By day 5, the defect had reduced to approximately half size as shown in image B, and by day 13, with continuous wear, the eye being checked daily, the lens removed, cleaned, and reinserted with a drop of moxifloxacin in the reservoir, she had healed. At 6-month follow-up, she looked as in image D. At 18 months follow-up, she was 20/40 as in image F. At 4 years, as in the image upper right, 20/40. She remains 20/40 to this day, still under my care. The bottom image shows the problem, which is the keratinized lid margins. The PROSE device protects her cornea from the margins, and she can retain good vision and good epithelial function. Case 2 is another case of Stevens-Johnson syndrome. An unfortunate 19-year-old had Stevens-Johnson syndrome in the setting of leukemia. She ultimately received a bone marrow transplant but developed blinding ocular surface disease with corneal melting in both eyes that was related to the SJS, not the Stevens-Johnson syndrome. Corneal patch grafts and transplantation failed, ultimately requiring total tarsorrhaphy in the right eye. The left eye did well with corneal transplantation and a PROSE device, but ultimately developed neovascularization and opacification over the following 2 to 3 years. At that point, the tarsorrhaphy was reversed in the right eye, and limbal stem cell transplantation was undertaken with her brother as the source of the corneal scleral grafts, much as he'd been the source of her bone marrow. This meant that immunosuppression wasn't necessary. After 3 months to allow the patch grafts to repopulate the surface under a PROSE device, she underwent corneal transplantation and cataract extraction with lens implantation. And the middle image in the top row is one week after cornea transplantation. And then in 2009, several years later, in 2014, long-term, where she retained 20/25 vision. The left eye continued to opacify, but she had good vision in the right eye until the time of her death in 2017, related to secondary sarcoma. Case 3 illustrates the advantage of PROSE treatment in chronic GVHD and exposure. This is a 44-year-old man who is treated for lymphoma with chemotherapy, radiotherapy, and allogeneic bone marrow transplant. He developed chronic graft-versus-host disease that left him with severe dry eye and exposure. In GVHD, there can be scleroderma-type infiltration of the skin, causing it to fibrose and tighten. For this reason, he had incomplete blink or leg ophthalmos. His eyes were red, irritated, and he had reduced vision. With the PROSE device, he was comfortable and maintained correction at 20/20 in each eye. Unfortunately, he developed facial sarcoma on the other side. The tumor was resected, he received radiation, and had reconstructive surgery, resulting in the appearance in the upper photo. That lower lid is entirely immobile and doesn't move, and the upper lid, because of the cranial nerve palsy, doesn't move. He has radiation keratitis, as you can see in the image below, with whorling of the epithelium. With all these limitations, he nevertheless retained 20/25 vision because of the PROSE device. The guiding principles in the management of severe ocular surface disease are to treat the local underlying processes, to treat the underlying systemic disease, to optimize the environment at the ocular surface, and this is where therapeutic lenses, soft lenses, gas-permeable scleral lenses, and PROSE treatment can make all the difference. And finally, adequate progenitor and amplifying stem cells are required. In conclusion, here are some take-home points from this lecture on the use of contact lens in ocular surface disease. I hope from the materials presented you've been able to understand the advantages and disadvantages of extended wear soft contact lenses, daily disposable soft contact lenses, mini-scleral and scleral lenses, and PROSE treatment. And now you can go to the literature for specific experience regarding chronic graft versus host disease, Stevens-Johnson syndrome, exposure, recurrent erosion, and Sjögren syndrome. It's important to respect the underlying disease, to use antibiotics and steroid appropriately. It's my recommendation that these patients be monitored closely, and indeed very closely. It's also my recommendation that the cornea specialist and contact lens specialist collaborate in the individual care of these patients. To CLASS 2020, I say thank you. Gracias, obrigado.